All right. Thanks, Shri. So hi, everybody. For those of you who don't know me, I'm Becca. I'm one of the R2s, and I'm in the primary care track. And today I'm going to talk about night sweats and how we can approach evaluating them and treating them in the primary care setting, and hopefully demystify it a little bit. So I have no financial disclosures. My main disclosure is that I am not an expert in this topic. And actually that there's not really a ton of literature about this topic. It's not really well studied. The data is limited and a lot of it is fairly anecdotal and based on like case studies, case reports, things like that. I did adapt some slides from a previous lecture by Dr. Courtney Teagle, who's one of the VA primary care docs. So our learning objectives for this talk, I'm hoping that we can review and understand the basics of sweating physiology, develop a differential diagnosis for some common causes of night sweats, determine key history features to ask when a patient is reporting night sweats to you, and then strategize an initial workup and or management strategy for night sweats. So just an outline of the presentation. We'll start with reviewing the physiology and going over some definitions. We'll talk about the epidemiology of night sweats. We'll go through some differential diagnosis with a couple of cases. We'll talk about an algorithm for initial workup, and then we'll end on some treatment options. So to bring it back to something that most of us probably haven't thought about since medical school, if really even then, the physiology of sweating. So there are 2 or 3 main types of sweat glands in our skin. The main 2 types are eccrine glands and apocrine glands, and you can see them here on this diagram. Eccrine glands are found all over the whole body, on all types of skin. Their highest concentration is on the palms of hands and soles of feet. They empty directly out into the skin, and they secrete mostly water and sodium chloride. Their role is primarily thought to be thermoregulation, but does also play a role in maintaining our epidermal barrier and allowing for like homeostasis in our microbiome that's on our skin. Apocrine glands, as you can see in the picture, are usually associated with hair follicles. They are primarily found in the axilla, breasts, face, scalp, and perineum, around hair-bearing areas of the body. Their role is less well understood. There's some thoughts that this is involved with pheromones and sort of maintaining that microenvironment as well, but again, not as well understood. They secrete a viscous lipid-rich sweat with proteins, sugars, and ammonia. And then there's apocrine glands, which are kind of a combination of these 2, and those are mainly found in the axilla. We're going to focus today's talk on the eccrine glands, as those are the ones that are involved in thermoregulation. So how do we sweat? How does our body know to start producing sweat? So our body senses increased body temperature with peripheral temperature sensors in the skin. And this can be through increased environmental heat, increased heat production by the body, or decreased ability to dissipate the heat that's being produced. This information is then sent to the preoptic area of the hypothalamus. This is the region of our brain that sets the thermoneutral zone. And when we're outside of the thermoneutral zone, that's when we feel hot or cold and start sweating. There's a lot of things that impact this thermoneutral zone. So circadian changes like cortisol levels, which we have all experienced on 20-hour call when you start sweating at crazy times because your thermoneutral zone is all off. Inflammatory mediators, cytokines that are released from infection, autoimmune diseases, or malignancy can all impact where our thermoneutral zone is set to. And then lots of medications can also impact this. Some medications include ones that have serotonergic effect, opioids, and anticholinergics. So once this part of the brain senses that we are above the thermoneutral zone, it sends a signal down the spinal cord to the peripheral pseudomotor neurons, and these are sympathetic neurons that then release acetylcholine onto the eccrine sweat glands. This peripheral response, and that causes us to sweat. This peripheral response is impacted by other things as well, and not just this input from the hypothalamus. Exercise, hypovolemia, adrenergic stimulation with catecholamines can also impact the peripheral sweating response. And then mast cell degranulation with histamine release can also cause us to sweat. So the point of this is that it's a pretty complicated process, and there's a lot of different things that play into why our bodies sweat and what causes them to sweat. And we don't really fully understand all of it. There's a lot of things that are at play here. There's other things too that can kind of reset our base point, like I mentioned. Over here on the left diagram, you can see that people's mean body temperature is at a baseline, and then the sweating rate will increase as the body temperature increases. That baseline, though, can be impacted by a lot of things. Training, living in a warm environment, increased skin temperature will lower that baseline, so people will sweat at a lower temperature. Similarly, with that diagram on the right, we can see that kind of the rate of increase of sweat production can change with some of these factors as well. So you can see that women tend to have a lower rate of increase of sweat as temperature goes up compared to men. And like athletes who are doing a lot of training, people who are acclimated to heat, they'll produce more sweat kind of at a more rapid rate as temperature goes up. So again, just showing some of the complexity of this. So to go over some definitions, hyperhidrosis is the secretion of sweat in excess of that that's needed to control body temperature. This can be focal or generalized. Sometimes people experience focal hyperhidrosis just on the palms of their hands or soles of their feet or their axilla, or generalized. And we'll be focusing on generalized hyperhidrosis. Night sweats are episodes of generalized hyperhidrosis that occur during sleep, as the name suggests. And then different authors in various studies have proposed different severity ratings. Some of the ones that I saw were that authors were classifying night sweats as mild if patients were not needing to bathe or change their clothing, and they were only reporting this after specific questioning. Moderate night sweats were classified as patients whose sleep was disturbed by the need to get up and wash their face or other body areas that were affected by the sweating, but they didn't need to change their clothing or their sheets. And they also counted this if the patient was volunteering this as a specific problem for them. And then severe night sweats were considered when you needed to change your clothing or bed sheets, and it was volunteered by patients often as drenching sweats. So why should we care about this? This is kind of a niche topic, I realize. But when I was looking into it, it's actually really a common symptom that our patients are experiencing. So depending on which study you look at, there's a range in how frequent this is in the primary care setting. Some studies say 10%, and then up to 41% of patients in a primary care setting are experiencing night sweats. So the biggest study that I saw was this cross-sectional study of like 2,300 adult patients in a primary care setting who were surveyed. 41% of those patients reported experiencing night sweats within the last month. 25% were only happening at night. And this is most common in middle-aged patients from 41 to 55 years old. And what I thought was interesting was that the majority of these patients had not reported these symptoms to their doctor, even if they were frequent and severe. And so this might be a problem that our patients are just kind of living with and not wanting to tell us about for various reasons. Another study later by the same author of about 360 patients, 34% of those patients did report night sweats, and then 50% of those reported that they were saturating their bedclothes. So again, pretty severe in quite a few patients. So I am curious what comes to mind for you guys when you think of night sweats. What are you worried about? What things do you think could be causing it? If you can just throw things in the chat or feel free to unmute. Okay, great. So I'm seeing lots of cancer, specifically hematologic malignancies, infections like tuberculosis, long call, yep, definitely Cody, thyroid, menopause, those are all, and medications, those are all really great, great thoughts that you're all having. So one of the biggest takeaways that I want to have is that our differential diagnosis for night sweats is actually huge. It covers basically every single organ system in the body. And we're not going to go through all of these today in this presentation. And this slide is also not meant to be exhaustive either. My plan is to go over some can't miss diagnoses. And then we'll cover some more diagnoses that we may be more likely to actually encounter and be able to treat in the primary care setting. Yeah, Cody, I see that kind of shocked emoji. I agree. When I saw this, I was mind blown. So the first one, the most common one that you guys mentioned in your differential was malignancy. And I think that this is the one that scares all of us the most, because when patients report this, we think of the B symptoms that we were taught in med school for lymphoma. And definitely this is something that's always really important to consider and not to blow off. They may be an early feature of many different cancers. Lymphoma is the most common. You want to consider that, especially if the patient is also experiencing fatigue, generalized pruritus or pain, or after these symptoms after alcohol consumption. And obviously, if they're reporting lymphadenopathy, you want to consider that. There's a lot of solid tumors that can also cause night sweats. The most notable ones are prostate cancer, renal cell carcinoma, germ cell tumors, and medullary thyroid cancer. Infections are the other next one that I really worry about, specifically tuberculosis. And I think quite a few of you mentioned that in the chat as well. So both pulmonary and extrapulmonary infections can cause night sweats. There's about like 50% of patients with TB do experience night sweats, and this is especially common in younger patients with TB. So you do want to be thinking about risk factors, especially patients who have emigrated from endemic areas or people who have spent significant time in endemic areas, or high-risk populations like the incarcerated, people living in communal settings. Also, HIV infection can cause this. Couple different stages, so both acute seroconversion of HIV, and then patients with advanced disease who now have opportunistic infection or HIV-related malignancies. Any bacterial infection can also cause night sweats, so you want to keep that on your differential as well, specifically like bacteremia, endocarditis, osteomyelitis, and pyogenic abscesses. So various places that infection could be hiding. And so definitely want to think about if your patients have risk factors for those things or other symptoms of an infection. And then viral and fungal infections. Infectious mononucleosis can also cause this. I actually, from personal experience, got mono during my first year of med school and had horrible night sweats, and everyone thought I had TB, but turns out it was just mono, thankfully. And then various fungal infections, and the most common one that I came across when I was reading about this was coccidiomycosis. So you want to ask about kind of geographic risk factors as well. And then I think this is one that we won't come across too much in the primary care setting as like initial diagnosis, but patients who have cervical or high thoracic spinal cord injuries can experience autonomic dysreflexia that can cause generalized hyperhidrosis and night sweats. So those are kind of the scary things that we want to make sure that we're not missing, and that I think all of us start worrying about as soon as a patient talks about that they're having night sweats. But what about less scary diagnoses? Are there other things that could be going on that are really much more benign? So we're going to go through a couple of cases to kind of go through some of the rest of this differential. So our first case is Ms. Hydrosis. She's a 45-year-old woman. She has a history of PTSD and migraines and a prior hysterectomy. She comes to clinic to establish care after recently moving to the area. So you're going to be her new PCP. She doesn't have any major concerns today, but does mention that lately she's been waking up damp with sweat. Sometimes changes her shirt in the middle of the night because of it. It's a little bit bothersome to her, but she's not really worried about it. So what additional questions do you have for her? Nightmares, great question. Hot flashes, mom went through menopause. Yep, great, Becca. Weight loss, fatigue, what climate did she move from? Med list, alcohol use, recent travel. Great, all great questions. History of GERD, yep. So you get, COVID test, great, Hillary. You get more history going through kind of your initial intake. So medications wise, she's on sertraline, 100 milligrams every day for her PTSD. She started that about 6 months ago with her prior PCP and feels like it's working fairly well for her PTSD. She's also on propranolol for migraine prevention, and then sumatriptan as needed. Her hysterectomy was without oophorectomy for fibroids. She doesn't have any family history of cancers or anything. On your review of systems, she's not having any weight loss. She hasn't noticed any lymphadenopathy, no fevers or chills or itching. She has no COVID exposures. And she is not sure when her mom went through menopause. Her mom also had a hysterectomy prior to going through menopause, but thinks it could have been around this time. So any thoughts now on what could be causing her night sweats? And no recent travel, and she's fairly certain that her room is not too hot at night. Menopause, yep. Anything else? SSRI, great. Yeah, so one of the first things that you should think of when your patients are reporting night sweats is looking at their medication list, especially if any medications have been started kind of around the same time that the sweats began. So there are a ton of medications that can cause night sweats for some patients. There was one study that I saw that looked at elderly patients in primary care setting, and they found 3 medication classes that were statistically significantly correlated with night sweats. And that was SSRIs, ARBs, and then not surprisingly, thyroid hormone supplements. And those all had an odds ratio of like you can see there 2.5 or up to 3.4 with a confidence interval that was statistically significant. But there's a lot of reports of other medications that have caused this. Like I mentioned at the beginning, there's just not a lot of great studies that have been done. But antidepressants are the most common. 10 to 15% of patients who are on antidepressants will have increased sweating. This might not just be at night, but some patients might really just experience the bothersome symptoms at nighttime. It usually occurs within several weeks of initiation, so it doesn't have to start right when they start the medication. It can be even 6 or 7 weeks later that they notice the sweating. All classes of antidepressants can cause increased sweating and night sweats. Actually, SSRIs are less common than TCAs, bupropion, and SNRIs to cause night sweats, but I think most of our patients who are on antidepressants are on SSRIs, so we'll see it more commonly with SSRIs. This is thought to be due to serotonergic effect on the hypothalamus and on the spinal cord directly, interestingly, and norepinephrine reuptake inhibition. Other medications that can cause night sweats include cholinergic medications like pilocarpine and bethanechol. As I mentioned, the acetylcholine is what acts on the eccrine sweat glands to produce sweat. Any estrogen or androgen modulating medications can cause night sweats. So patients who are on GnRH agonists, aromatase inhibitors, SERBs, androgen receptor blockers, all of those medications can cause it. Opioids, but specifically methadone, is known to cause increased sweating. So that's something to keep in mind. Albuterol is like rarely or sometimes reported. Antipyretics, so like Tylenol, Advil, and NSAIDs can cause it, and decongestants. So I thought those last two are kind of interesting as something that patients might just be taking over the counter. So important to ask about that. Cody, I agree. Serotonin is confusing to me as well. And we'll get into it, but SSRIs can also be used to actually treat night sweats. So it's a little confusing. I found this chart in one of the studies that I was reading that's about kind of where all these different medications can act in this pathway to cause night sweats. And I will never remember this. I don't expect anyone else to remember it, but it's just interesting to see. Again, this is a really complex system, and that's why so many different medications can impact this. You can see all the different spots that it can play a role. So like up in the hypothalamus, I mentioned earlier, opioids, SSRIs, tricyclic antidepressants can all act there. Opioids can cause mast cell degranulation, which the histamine can then cause sweating. Medications can impact the neuroendocrine junction. They can impact the spinal cord and the sympathetic chain ganglion, and just like literally everywhere in this pathway can be impacted by medications. So just to keep in mind. And then while we're thinking about medications, on a similar vein, substance withdrawal can also cause night sweats. I think somebody mentioned in the chat, like asking about alcohol use. Both alcohol use and alcohol withdrawal kind of over time can cause night sweats. Opioid withdrawal and cocaine withdrawal can also cause night sweats. So really these substances, both while using and withdrawing from them, can cause this. And then somebody also mentioned thinking about menopause for this patient. So there's a lot of endocrine causes for night sweats as well. And I should have put menopause here first. Yes, this is a really common symptom of menopause, and some women may experience just night sweats and not hot flashes as we classically think about them during the day. But it's really important in patients who are of menopausal age to not just kind of latch onto that too early, like premature closure. You want to make sure that you are thinking about some of these other causes, but it is a really common experience. Another thing that I found that I thought was really interesting from an endocrine cause of night sweats was diabetes, specifically that night sweats may be the only symptom of nocturnal hypoglycemia. So patients maybe like if they're missing their evening meal, or if they've done unusually like strenuous exercise in the evening time out of their normal, or if they're using large evening doses of insulin, maybe experiencing hypoglycemia at night and just having night sweats, and that's their presentation. You want to worry about this specifically in patients who have really tight control of their diabetes, so like a lower A1C, patients who also have renal insufficiency, polypharmacy, patients who are on high doses of insulin or sulfonylureas, and then also older patients. As we know, we want to have less tight control in those older patients as well. And then other things that we know of, hyperthyroidism can cause night sweats, and then some rare things like pheochromocytoma and carcinoid syndrome can also be endocrine causes of night sweats. Rebecca, I see your comment in the chat. What does the timeline look like for sweat with alcohol withdrawal? Is it only during active withdrawal, or could it occur weeks or months after someone stopped drinking? That's a really good question. my answer to that is based on anecdotal sort of evidence that I came across while researching this, and that what it can be during acute like active withdrawal as a sign that, like, you know, if they're in the hospital, they need more benzos or more treatment for their withdrawal. But it can also, I was reading some case things about patients who were having night sweats kind of for weeks or months after stopping drinking. So it's really variable patient by patient, and it doesn't have to just be like active withdrawal. All right, so those are our considerations for myshidrosis. Now we're gonna get into our second case here. This is Mr. Hydrosis. He's a patient of yours. He's 54 years old. He has a history of hypertension, hyperlipidemia, and hypothyroidism, and he comes in just for kind of annual checkup. On his review of systems, when you're thinking about his thyroid medication and making sure he's still on the right dose, he does mention that he sweats at night pretty often. His meds are levothyroxine, lisinopril, and simvastatin. So what else do you want to know? Other B symptoms? Yep. What is TSHs, levothyroxine? Great. All right. So additional review systems, like no other B symptoms. He hasn't had weight loss, no fatigue, no itching, no lymphadenopathy. You check his TSH and it's normal at 2.4. His exam, he's a larger guy, but it's unremarkable. On additional review systems, he does note that he kind of wakes up feeling pretty fatigued, has intermittent acid reflux symptoms. Yeah, I see, Lindsay, your question about the stop bang score. That's a really great thought and a great question. So our next consideration here is sleep disorders. So sleep disorders are more common in patients with night sweats. It's unclear kind of what the chicken or the egg is here. Is it that the sweating is waking people up and then they're not sleeping well, or are they sweating because of their sleep disorder? Again, not great data on that. Night sweats are associated with symptoms including daytime tiredness and, interestingly, legs jerking during sleep. And then the main sleep disorder that has been kind of shown to be related to night sweats is sleep apnea. So there was a 2013 study of 700 patients with sleep apnea who hadn't yet received any kind of positive pressure treatment, and they compared it to 700 patients in the general population. Prior to getting any treatment, about 30% of the sleep apnea patients reported frequent nocturnal sweating at least 3 times per week, compared to about 10% of the general population. And that was a very statistically significant result. And then after the patients were treated with some kind of positive pressure treatment, either CPAP or BiPAP, that number decreased from about 33% of patients experiencing frequent night sweats to about 11% compared to patients who were not treated with PAP. And then there's been some evidence of, someone mentioned in the chat earlier, patients who are having nightmares, night terrors. And then I was also, because of this legs jerking during sleep, I didn't read this anywhere, but I was wondering if maybe restless leg syndrome could also be associated with this. So again, lots of sleep problems. And then GERD symptoms, Cody mentioned in the chat. So this was one of the things that I was most interested to learn can cause night sweats, is acid reflux. So this is, again, really based on observation, no formal trials. There was a cross-sectional study that found that night sweats were associated with waking up with a bitter taste in the mouth. They did not go further than that to like talk about if those patients were experiencing GERD or what that bitter taste in the mouth was, but I'm assuming that's what that was. And then there was this guy named Reynolds. He was a GI doc back in the 80s, and he wrote into the Journal of Clinical Gastroenterology about this kind of case series that he had. And he had 200 patients, and 12% of them were reporting weekly night sweats. 80% of those 24 had reflux symptoms, and 12 of them were given anti-reflux treatment that was not a PPI, so something like probably at the time ranitidine, and their sweats completely resolved. So for all 12 of those patients who did receive treatment. Since then, there have been a few case reports and case series that have shown similar things where patients had some GERD symptoms and night sweats. They treated the GERD, the night sweats went away. So what are we to do in clinic when somebody reports night sweats to us? So the main thing is getting a really good history. Like you guys mentioned kind of in the chat when we were going through what to do about these patients, really getting a good history of other contributing factors that could be going on is the main thing that's important. So mild sweats are typically less concerning. Patients who are not like reporting it unless you're specifically asking it, and then they don't have to change their clothes or their sheets at all during the middle of the night. That's a lot less concerning than somebody who's reporting drenching night sweats. And also the more frequently they're happening, the more concerning. So if they're happening every night, that's a lot more concerning than somebody who says that it happens like once or twice a month. You want to also ask about the temperature of their bedroom and if they have like too many covers on, if they're just too hot. Night sweats by definition are hyperhidrosis. And so that needs to be that they're sweating in excess to what is needed for thermoregulation. So excluding the fact that maybe they just like have a bedroom that's too hot or too many sheets, or they have like dogs in their bed that are keeping them hot. So asking about all those things is really important. The other thing that when I was reading about this is one of the biggest things to rule out is the presence of a fever. So you want to ask if patients are feeling feverish when they're waking up with night sweats. And then if possible, you want them to really be taking their temperature when they are having these episodes, during and after the sweating episodes. And then also it's recommended to have them check their temperature at other random times. I will say in practice, when I've had patients with night sweats, I've never actually done this, but might be something that I ask patients to do in the future. You want to ask about risk factors for various infections. Tuberculosis risk factors, like if they've ever had another positive TB test, a known exposure, living in some kind of institutionalized setting, or experiencing homelessness or immigrating from an endemic area. You want to ask about HIV risk factors, which we all know, multiple sexual partners, IV drug use, and if they're having any symptoms that might point you to HIV, like thrush, diarrhea, weight loss. You want to ask about COVID exposures now that we're in the COVID era, tick-borne diseases and various exposures. The main one for that is the babesiosis. So if they live in an area endemic to that, and if they do outdoor activities. Somebody mentioned in the chat earlier, malaria. So yeah, if they've traveled to an endemic area, fungal infections like coccidiomycosis, and then risk factors for bacteremia, like if they have indwelling catheters, if they're having any symptoms like localized pain, like back or joint pain, any history of IV drug use, history of endocarditis, and if they have like risk factors for endocarditis, if they've had recent dental work done. You want to ask obviously about other like B symptoms and constitutional symptoms, like weight loss, fatigue, pruritus, lymphadenopathy, and any personal history of malignancy as well. If they have that, that should kind of raise your red flags. You want to ask about their hormonal status, if they could be going through menopause, if they're taking other estrogen-containing products or undergoing androgen deprivation. Other endocrine symptoms like signs or symptoms of hyperthyroidism, which we all know, carcinoid syndrome, like wheezing, diarrhea, episodic flushing or PHIO with palpitations or headaches, And then their medication history, any sleep disturbances, and any reflux symptoms. So this is like quite the list of things, and you probably don't have time to ask like all of these unless you have a really dedicated visit to talking about the night sweats, but you can kind of run through and get rid of some of the red flag things at least, and make sure that there's nothing really scary going on. And then we get into physical exam. So this is also important, but I think might not be as elucidating as the history, but you do want to make sure you're looking at their general appearance. Do they look cachectic? Do they look well? Their vital signs, especially focusing on if they have a documented fever, comparing their weight to prior, making sure that their blood pressure is normal, and then that the heart rate is normal as well. You want to examine all their lymph node chains, so both anterior, posterior cervical chains, supraclavicular, and inguinal lymph node chains. You want to check for thrush, for thinking about HIV infection, for thinking about hematologic malignancies or other hematologic disorders. You want to check for mucosal petechiae or pallor, and then for hyperthyroidism, Lulager exophthalmos. You want to check their abdomen for masses or splenomegaly, again, thinking about malignancy. Listen for any new murmurs, listen to the lungs for abnormalities, especially wheezing if you're thinking about carcinoid syndrome, and then if indicated by history, a neurologic exam. And then we get into kind of diagnostics. So the diagnosis can really be based on if they have a presentation that really is consistent with an illness script. And so, if they have lymphadenopathy and they have no recent infection, they'll probably end up getting like a lymph node biopsy because your suspicion for lymphoma is a lot higher. If they have things that are consistent with TB, you want to test for TB and get a chest x-ray. If you're worried about HIV, you can get an HIV test. If there's signs and symptoms of endocarditis, you want to get obviously blood cultures and an echo. If they have upper respiratory infection symptoms, you can get a monospot test. Important to note that in the first week or so, this could be a false negative. If it comes back negative, it could still turn positive at a later date, and checking a complete blood count. If you think that they might be menopausal, but you have questions specifically, like in our case with the patient who had a hysterectomy but still has ovaries, you can check an FSH if there's any concern. And if you want to just make sure that they truly are undergoing menopause, and you can also try hormone replacement therapy or other treatments that we'll get into in a little bit. And then if you're concerned that they might be hypoglycemic, you want to have them check their blood sugars during the episodes of sweating. Sometimes something like a continuous glucose monitor could be helpful for this, but obviously really difficult for our patients to get in most circumstances. And then if they're having like symptoms of a pheo or a carcinoid, you can specifically test for those diseases as well. But what to do if history or physical, is not really leading you down one specific path? This is a proposed algorithm that was published in American Family Physician in, I believe, 2020. Yep. So if the patient does not have any fever, weight loss, or lymphadenopathy, and they have a presentation that could be consistent with one of these clinical diagnoses that are less scary that we talked about, you can trial treating that condition as appropriate for a month or two and kind of seeing if that improves their symptoms. So for example, if they don't have any of those red flag signs and they're on a medication that you think could be causing it, you can try withdrawing that medication, substituting it with something else, or decreasing the dose. If they're talking about GERD symptoms, you can try treating them with either a PPI or even just an H2 blocker for a couple of months and see if their symptoms resolve. If you're worried about sleep apnea and they have a CPAP and they're not using it, you can try that, or testing them for sleep apnea. And then if you're concerned about menopause and you have questions, you can check an FSH or trial treatment. If after this trial their sweats resolve, you're good to go, and you can just kind of continue to monitor for any recurrence or concerning symptoms and kind of educate your patient about those red flag things to look out for, like weight loss or fevers or lymphadenopathy. But if the first condition is not true, they have any of those red flag signs, or they don't really have symptoms that are pointing you down one of those pathways, or their sweats don't resolve after an empiric treatment, initial testing to consider would be the tests that are listed here. So this is kind of what's been proposed both in a couple different algorithms like this and on UpToDate. The initial tests would include a CBC, getting some kind of TB test, whether that's a PPD or a quantiferon gold blood test, checking a TSH, checking an HIV and an ESR and CRP, and then also getting a chest x-ray. So the reasoning behind these tests are that they're like fairly cost effective, and they'll screen for some of the more common and red flag kind of can't miss diagnoses. So you'll get a CBC to look for any abnormalities that might make you worry about a hematologic malignancy, tuberculosis, which I thought was kind of interesting, especially in the general population where we live, probably less common, but fairly cost-effective tests. Obviously checking a thyroid, and then the ESR and CRP helps point you down a pathway of like, are they having inflammation from somewhere? So you get those tests. And if the results are diagnostic or point you down a path, that's great. And you can treat or more likely refer as indicated by the results of those tests. If they're not diagnostic, this is where kind of all the algorithms break down, and there's a bunch of tests that you can consider, but that, you know, some of them specifically like a bone marrow biopsy are fairly invasive. So you want to base it on your like clinical judgment and concern for certain conditions. Like if you're really concerned that they might have a malignancy, that would involve the bone marrow, that's a reasonable thing to do. Obviously, we probably would not be ordering that ourselves, but something to consider. Also a CT chest or abdomen to look for malignancy, expanded lab testing, like that testing for PHIO with metanephrines or carcinoid syndrome with the 5-HIAA. You could consider getting a sleep study in these patients as well. And some authors argue that at this point you could consider empiric GERD treatment as well, just to see. Sometimes patients aren't super aware of their reflux symptoms, but treating for GERD could potentially cause resolution. And at all these points, you want to kind of be revisiting all those illness scripts and thinking if there's any new symptoms or anything else that's pointing you down a certain pathway. And then once again, if the results are diagnostic, great, treat or refer is appropriate. And if you've done like all of these things within reason and they're still not pointing you to a diagnosis, everywhere that I came across said like it's okay to just kind of continue monitoring them and like kind of do some watchful waiting and assuming that anything that is scary will continue to declare itself, and otherwise just like making sure that no symptoms are developing, which I thought was a little bit scary to just kind of not have an answer for why your patient is having night sweats. But that it's okay. And actually, there's been some studies about the prognosis, the prognostic indication of night sweats, and that night sweats by themselves do not indicate increased mortality or morbidity in our patients. So they might not be as scary as we think they are. And so as primary care doctors, our job is not just to diagnose and refer and, you know, treat underlying conditions, but also sometimes just to treat patients' symptoms, because night sweats can be really distressing to patients, even if they know that it's being caused by something that's benign and not going to kill them. It still impacts their quality of life. So knowing how we can kind of alleviate some of those symptoms is also important. So for patients who are undergoing menopause, obviously you can think about hormone replacement therapy. And interestingly, you can also consider SSRIs and SNRIs, which I thought was fascinating that it can treat night sweats in these patients, but can cause night sweats in other patients. Paroxetine is the only one, I believe, approved by the FDA for treatment of hot flashes, but I think paroxetine is kind of a pain to prescribe because of its short half-life. So other medications that have been shown to be effective are citalopram and venlafaxine. And then gabapentin is also helpful for patients undergoing menopause who are having night sweats. You can even just use a single QHS dosing of gabapentin, and that can be really helpful in getting rid of the night sweats for patients. For patients who are on chronic opioids, specifically methadone, you can try oxybutynin, and then there's been some evidence of antihistamines also helping. If you remember that diagram, that opioids cause mast cell degranulation, which can cause sweating. So that's the mechanism that antihistamines can be helpful. I saw one case report where a patient was started on like QID oxybutynin, 5 milligrams, and his night sweat stopped within 2 days. For patients who are on SSRIs and like being on an SSRI otherwise, but are bothered by their night sweats, but they don't want to stop the SSRI, terazosin is the most well studied for treating night sweats in this situation. There was a case series that showed that 23 patients with night sweats on SSRIs were treated with terazosin, and 22 of those 23 patients, their symptoms improved. Benztropine and clonidine have also been shown to be effective. And then just lastly, for patients who are for treating the symptoms of night sweats caused by medications, I know it's not ideal to treat medication side effects with more medications, but sometimes, like I mentioned, like for SSRIs or other medications, patients really can't come off of the medication or don't want to come off of the medication. And so things that you can consider are systemic anticholinergics like glycopyrrolate or oxybutynin, clonidine, and then topiramate can all be used to treat night sweats in those cases. So just to kind of revisit our learning objectives and some take-home points. So we wanted to understand the basics of sweating physiology. We just want to remember that it's a complex process. The thermoregulatory centers in the hypothalamus, and the thermoneutral zone that's set there is impacted by a lot of different factors. We wanted to develop a differential diagnosis for common causes of night sweats. And my main takeaway here is that I want you to think about all the organ systems, and that there's many different reasons why patients might be having night sweats. But importantly, to consider not just the can't miss scary diagnoses like cancer and infection, but you also want to think about common things like medication side effects, acid reflux, sleep apnea, menopause, things like that. And then obviously don't forget to at least consider those can't miss diagnoses. And then we want to determine key history features to ask when a patient reports night sweats. So asking about risk factors for infection, other symptoms, especially B symptoms, and any medication changes. And then to strategize an initial workup or management of night sweats, consider illness scripts and workup as appropriate. It's okay to trial a treatment for things like GERD, medication, menopause, and sleep apnea if there's no red flag features. And then initial tests to get would be a CBC, HIV, TB testing, TSH, ESR, CRP, and a chest x-ray. These are my references. And any questions? I see that there's some things in the chat. Maybe it should be an earlier question, but since it's more of a subjective complaint, what's your threshold to start workup with the lack of other objective findings or explanation like meds, menopause, etc.? Yeah, so it really kind of depends. Up to date says that if the patient, if they're like under the class of mild night sweats, then you really don't have to do other workup. My threshold that I've been kind of using to kind of pursue other workup is if the patient volunteers it to me as something that's bothering them. And then I just kind of make sure that they at least have like a recent CBC. I don't necessarily reorder things. And if I don't have suspicion for TB, I have not yet ordered a TB test in a patient who's reported night sweats to me, but have tried to think about illness scripts and initiate treatment as appropriate for those. So yeah, I guess if they're telling you that they're having severe drenching night sweats, I would probably definitely get all of those things that are mentioned in the initial workup if there's not something obviously standing out. But if they're mild and intermittent, then I would worry less.
All righty, Becca. That was a great talk. I just love the framework and so many things I did not know. So I really appreciate you for opening my eyes to various causes of night sweats. Let's take 3-minute break or so, 10:48. We'll get a little late start for Kelvin's last talk on choice architecture.